Raja Magendran, can we start the program? Dr. Shankara Narayanan,
Good evening, sir.
can you please check with Namachivayam sir and Suresh Kumar sir?
Yes, sir. Good evening, sir. Yes, sir. Yes, sir. Sir, Suresh Kumar, sir, he will join by around 9 o'clock. After
Okay.
9 o'clock, sir. Yes, sir.
Okay. Namachivayam sir is going to join. Namachivayam sir.
Yes, sir. He will definitely join, sir, I think.
Yeah. Raja Magendran sir.
Yes, sir.
Can we start and Namachivayam sir will join, or we have to wait for him to join?
Sir, I'm trying to connect him, sir, actually.
Yeah,
1
please,
minute.
please let me know.
Hello, good evening, sir. I've contacted Namachivayam sir. Sir said he'll not be able to join today, sir.
Oh, okay. Okay. Then Raja Magendran, can we start? Suresh Kumar sir is going to join, or you'll also? What is the plan?
Sir said Suresh said will be coming at 9, sir.
Yeah.
Uh,
We remind
so-
to you. Probably till the time that Raja Magendran can take over the session.
Okay, sir. Yes, sir. Yes, sir.
Yeah, we'll start.
I spoke with Namachayam sir too, sir. He is out of station. He is currently in Manipal, sir. He is not
Okay.
joined.
Okay then. Then take over the session, Raja Mahendran, and just let 15 minutes just try to engage. Probably that Suresh Kumar will join, then we can take over further session of this session.
Okay, sir. Yes, sir. Yes,
Yeah,
sir.
yeah.
Yes, sir.
Let me introduce and start the program. I think
Yes,
good evening and welcome you all for this virtual ICP API postgraduate training program. And we have with us this week also the faculties from Department of Medicine and Department of Cardiology from KPB Medical College, Trichy. We have with us Dr. Raja Mahendran, the Professor of Medicine from KPB Department of Medicine. Thank you, sir, for being the faculty this evening. And we have with us going to expect the joining of Assistant Professor and Consultant Department of Cardiology, Dr. Suresh Kumar is going to join soon. And we have the postgraduate from Department of Medicine, KPV Medical College, Trichy. Dr. Shankar Narayan is going to present a case on congenital heart disease. Over to Dr. Raja Mahendran and
yes,
expecting Dr. Suresh Kumar to join, and both of them will take over for the proceedings of the session.
yes.
Over to postgraduate and the faculties. Thank you.
Thank you so much, sir. Thank you, sir.
Thank you, sir. Sir, shall I start presentation, sir?
Shankar, please start.
Yes, sir. Good evening, all present here. Today I'm here to present a case of detailed septal defect. So, patient details. Patient name Mrs. X, who is a 50-year-old female coming from Perambalur, who is a daily wage laborer by occupation, coming from lower socio-economic status, was admitted to the hospital with the chief complaints of breathing difficulty for the past 1 month, history of bilateral swelling of the legs for the past 10 days, and history of easy fatigability for the past 10 days. History of presenting illness. The patient has had a history of breathing difficulty for the past 1 month, which was insidious in onset, gradually progressive in nature. It had progressed over the last 10 days such that the patient experienced breathlessness on carrying out less than ordinary physical activity, which was coming under NIHA class 3. The patient also had episodes of breathlessness after around 2 hours of sleep in the night, after which relieved after 15 minutes of sitting up posture, which suggested history of paroxysmal nocturnal dyspnea. The patient also had breathlessness, which also worsened immediately after leaving supine posture, which suggested history of orthopnea. There is no associated platypnea or orthodeoxia. History of bilateral swelling of the legs was present for the past 10 days, which was initially at the level of her ankles and had progressed up to mid-calves, which partially got reduced on limb elevation. It was not associated with any facial puffiness or abdominal distension. History of easy fatigability was present. And there was no other history of chest pain, no history of cough with expectation, no history of fever, no history of loss of consciousness, no history of abdominal distension or abdominal pain, no history of multiple joint pains, no history of sore throat, no history of blood in sputum, no history of reduction in the urinary output, no history of cyanotic episodes, no history of recurrent respiratory tract infections, no history of voice change or hoarseness of voice, no history of dysphagia. Past history, the patient didn't have any history of similar complaints in the past. The patient was diagnosed to have a congenital heart disease during her 4th pregnancy and has been on treatment and observation since. And the patient had no other known comorbidities present. Family history, the patient was born from, the patient had a non-consanguineous marriage. There is no history of similar complaints in the family members, no history of sudden cardiac death in the family members, no history of heart disease in the family. Personal history, she's a mixed diet consumer with a normal bowel and bladder habits, and she's not a smoker or not an alcoholic, and no other adverse social habits. Menstrual history, the patient had an LMP of 14, 12, 25. It was regular cycles with normal flow, not associated clots. Obstetric history, the patient had been married since 30 years, and her P4, L4 is obstetric code with all 4 normal vaginal delivery, but only on the 4th pregnancy had she been diagnosed to have a congenital heart disease. Tubectomy was done 20 years back. So, summary, a 50-year-old female who's a daily wage laborer coming from low socioeconomic background, who's a known case of congenital heart disease, presented with complaints of progressive exertional breathlessness, which progressed to NIHA class 3, currently associated with paroxysmal nocturnal dyspnea and orthopnea, with bilateral symmetric pedal edema and easy fatigability. The probable system involved is the cardiovascular system.
Shankar?
Sir.
Good pa. Just go with the first slide pa.
Yes, sir. This slide, sir.
Yeah, good one, good one. Yes.
Yes.
So tell me pa. So if you are dealing with the case of 50-year-old female with a breathing difficulty of 1 month, bilateral leg swelling of 10 days, and EC fatigability of 10 days, what do you think pa?
Sir,
So
in
for
our Indian
patient is a known case of cardiac congenital heart disease or something, just to forget that. So
Yes, sir.
what comes to your mind? If this is the history, chief complaints alone, you are considering these three, what would be your opinion?
The first differential diagnosis, I would have considered anemia with the failure patient, because in our country, most common in this age group, anemia is more common, sir. So the patient could have anemia with the failure features, sir. Second, it could be the patient could have any undiagnosed ischemic heart disease which had progressed to failure, sir.
Okay.
Or it could be a patient could also have heart disease complicating any dilated cardiomyopathy, sir, with failure features presentation, sir. Mostly breathing difficulty, swelling with easy fatigability. These are the common differential diagnosis. Or it could be any valvular heart disease. Most commonly in our country could be rheumatic of origin, which had would have been undiagnosed in this patient, which could have progressed to failure, sir.
Okay. So if at all, if only past history until now is the known heart disease, especially congenital
Yes,
heart disease, you made a statement like congenital heart disease. So
yes.
on congenital heart disease patient presented, we don't know exactly the congenital heart disease, what exactly congenital heart disease, whether she undergone surgery or not, we don't know. So if at all underlying congenital heart disease, if somebody comes to you with these three symptoms, what do you think? What comes to your mind? Known congenital heart disease, now admitted with breathlessness, leg swelling, fatigue.
Yes, sir. We could patient could be having a acyanotic congenital heart disease progressing to failure, sir. Most common cause it could be, sir. Because if there will be cyanotic heart disease, now there will be any patient will have cyanosis or clubbing history will be present from the history, sir. But since patient has only breathing difficulty, bilateral swelling of the disease, most commonly it could be any left to right shunts which produce proceeding to failure features, sir.
Okay. So whatever may be the shunt lesions, now the patient presented with both the left heart failure and right heart failure symptoms, both.
Yes, sir.
So if at all, if you are thinking in terms of a left to right shunt patient, congenital heart disease with a left to right shunt, now the patient lands up with reversal or whatever, right heart failure symptoms, right? Okay.
Yes, sir.
Okay. We need to. So don't think only the congenital heart disease means only ASD, VSD, PDA. So congenital heart disease means you need to include valvular heart disease also.
Valvular stenosis. Yes, sir.
So go to the next slide, man.
Yes, sir.
Okay. So tell me the NIHA classification. What are all the symptoms classified by NIHA?
Fatigue, sir. Dyspnea, chest pain, sir, and palpitations, sir.
Yes. So all these four symptoms can be
classified under NIHA.
Yeah, graded by NIHA. So that's why I repeatedly telling that if you are saying history of fatigability is there, you have to tell whether it's a NIHA 1, 2, 3 or 4. So for NIHA, they will not mention as specifically as chest pain or breathlessness. They will mention as symptoms. So you need to replace breathlessness, chest pain, palpitation, fatigue in place of symptoms. So during NIHA, they will mention as only symptoms, right? Class 1, 2, 3, 4. Okay. Okay. So could you able to explain the reason for paroxysmal nocturnal dyspnea and orthopnea in the case of cardiovascular system disease? Why everybody is saying it's specific for cardiovascular related breathlessness?
Sir, for cardiovascular system, first earlier symptom which which we can see is the paroxysmal nocturnal dyspnea, sir.
Hmm.
That occurs because when a patient is in a lying posture, there will be increased from the interstitial space, the fluid goes into the intravascular compartment, due to which there will be the intravascular expansion occurs during lying posture, sir. Along with that, patient in a paroxysmal nocturnal dyspnea typically develops breathlessness 2 to 2.5 hours after the onset of sleep, sir. When in that time there will be a decreased sympathetic drive to the heart associated with the respiratory symptoms will be suppressed during that time, sir. So only around 2 to 2.5 hours after the onset of sleep, he develops a breathlessness during which he awakes from the sleep. He has air hunger during which he goes to the windows and tries to breathe to get air. He goes out, sir. And the breathlessness, it does not immediately resolve on sitting posture or standing posture, and it takes about 30 minutes to settle, sir. But however, in a case of orthopnea, the patient on immediately lying down around 10 to 15 minutes immediately develops complaints of breathlessness, and immediately on sitting, he really gets a relief of symptoms around 2 to 5 minutes after, sir. So first, paroxysmal nocturnal dyspnea occurs, which progresses to orthopnea, sir. So this is all
So,
occurring because of the increase in the increased venous pressure, pulmonary venous pressure. We need to increase pulmonary capillary wedge pressure, sir.
okay, Shankar. Good. Very good. But this patient was apparently normal 1 month back, right? As per your
Yes, sir.
statement. So
Yes,
even
sir.
though she is a known case of congenital heart disease, she was apparently normal 1 month back.
Yes, sir.
So for the past 1 month only, the patient is having gradually progressed from class 1 to class 3
Yes,
in
sir.
a span of 30 days.
Yes, sir.
So some triggers might be there, no? So
Yes, sir.
what worsens this failure from the history? Could you able to make out what would be the triggers?
Sir,
No, this in there. 50 years, the patient is having congenital heart disease. Up to 1 month back, she was almost normal, right? As per your statement.
yes, sir.
She
Yes, sir.
developed this, all symptoms for the past only 1 month. Even this 1 month,
Any,
the patient,
yes, sir.
I mean, you are saying gradually progressive. I can say it's
Yes, sir.
rapidly progressing into, within a span of 30 days, she reached
Yes, sir.
state of class 3.
Yes, sir.
What could
Any
it be?
superimposed anemia could have been worsening the already uh, patient having a cardiac disorder. Anemia could have precipitated, sir.
Okay,
Or
good.
it could be any respiratory tract infections, but history-wise, she's not having any cough. Maybe
Okay, infections can be, so you
yes, sir.
can roll out from the history. Okay.
Yes, sir.
Anemia. Okay, I may consider. Okay. Any other thing?
If she had a congenital heart disease, suppose if it is an congenital heart disease, sir,
Yes.
the patient would have been compensated till now, and worsening have occurred because worsening could have occurred during this age group, sir.
During this, look, it's 1 month, the patient can completely worsen, I think, right? So
Yes,
you
sir.
need to
Yes, sir.
consider arrhythmias. So any congenital
Arrhythmias,
heart
yes, sir.
disease, valvular or non-valvular heart disease, or any acute valvular acute disease, arrhythmia is the
Yes, sir.
one potentiating that down spiraling the course.
Okay,
So
sir.
you need to consider associated arrhythmias. Okay, then what else could have happened? Okay, that
Any
reversal.
ischemia? Yes, sir.
Yeah, yes. Associated ischemic heart disease. So the
Yes, sir.
patient is having congenital heart disease doesn't mean she could not have been associated ischemic heart disease, right? There is
Yes, sir.
still a possibility. Associated coronary
Yes,
artery disease, good. Associated arrhythmias, associated coronary artery disease, associated
yes, sir.
intercurrent infections,
Yes, sir.
associated worsening of anemia. Okay, good. So then other complications like infected endocarditis, if at all congenital
Yes, sir.
valvular or non-valvular heart disease. So infective
Yes, sir.
endocarditis may be the triggering factor for this rapidly worsening
Sir.
cardiac failure symptoms, right?
Yes,
So
sir.
you need to rule out all these. Okay, good.
Yes, sir.
Okay, next slide, man.
Yes, sir.
Okay, where do you ask the history of all this? So Namkevas, are you asking, or do you want to ask this history for any specific reasons? Chest pains, cough with
Chest pains
expectoration.
in intercurrent infections, fever history, sir. As we said, any recurrent respiratory infection, or even if it
Okay,
is
most of the time, that worsening of cardiac failure, you need to rule out infections.
Yes, sir.
So any infections, maybe a pneumonia, maybe urinary tract infection, any infection will worsen the cardiac failure status. LV function might be rapidly deteriorating, right? Okay, good.
Yes, yes, sir.
Why would you ask the history of loss of consciousness?
Because transient loss of when if it is a reduced cardiac output, patient can develop any syncopal episodes.
Would you be able to define syncope?
Syncope is the transient loss of consciousness associated with loss of postural tone occurring due to global cerebral blood flow supply being impaired, sir.
Good.
And this is the definition of syncope.
Then one more adjective has to be added. So it's a sudden transient loss of consciousness. Good. With associated loss of postural tone. That's also nice. But you need to add with spontaneous recovery without any intervention. So you need not to give any intervention. So the patient has to regain his consciousness and regain his posture without any intervention. So then only you can label as syncope, right?
Okay. Yes, sir.
Okay, good. Okay. Then abdominal distension and abdominal pain for right heart failure symptoms.
Right heart failure symptoms.
Okay. Then why did you ask history of multiple joint pain?
Sore throat, if any rheumatic, if past history should have any rheumatic or fever history. But
this is the presenting illness, no? You are asking currently whether the patient is having joint pains or not. This is the presenting illness.
Okay.
Why would you ask?
It should have been mentioned maybe in the past history, sir.
If you are trying to say, you can say infective endocarditis. So infective endocarditis might present with joint pains, multiple joint pains. That's associated possibilities, right? Okay.
Okay. Yes.
Then blood in sputum.
The patient had a pink frothy sputum can be produced in pulmonary if the patient has
pulmonary edema.
Yes,
okay. Then what about cyanotic episodes? Why did you ask the history of cyanotic episodes? What is that cyanotic episodes? What do you mean? Are you going to say it's a cyanotic spell?
Spells actually, sir, because it actually occur in pediatric age group patients. Usually, cyanotic spells are TET spells, sir. Typically occurring in technology of patients, sir.
Okay.
Mechanism is that.
Actually, I'm not asking about the mechanism. Just the 50-year-old female. Are you going to ask the history of cyanotic spell?
It will not
is
be
it possible
relevant for
to
this
have
age.
Congenital cyanotic heart disease at this age group? Congenital cyanotic heart disease.
If correction had been done in the earlier age group,
yes. So there is something called Nada's dictum, right? So if you are coming across one congenital cyanotic heart disease in an adult patient, means it should be Fallot's physiology until proved otherwise, right? So it's only possibility in adult congenital cyanotic heart disease is Fallot's. So Fallot's tetralogy means it's a Fallot's physiology. So you can get, but cyanotic spell at this age, it's okay. So how the patient will usually present during TET spell? What are the history you need to ask? Cyanosis is different. Cyanotic spell is different, right? Is it occurs in paroxysms?
Yes, sir. During crying or feeding, the patient develops because of
what exactly happened to the baby or kid? What will happen? Will the patient feel breathlessness or not? Or only becoming cyanosis? Will the patient lose his consciousness, his or her consciousness?
During crying or feeding, there will be bluish discolorations of the mucous membrane and the skin occurring because of the there'll be already present right to left shunt will be even more accentuated because of the decrease in the systemic vascular resistance.
Yes. So the history should be worsening of cyanosis. So spell means the patient will be already cynosed. Cyanotic congenital heart disease means usually centrally cynosed, right?
Yes,
So,
sir.
but the
Yes, sir.
cyanosis will worsen associated with breathlessness.
Yes, sir.
So
Okay.
patient might become unconsciousness, may thrown into seizures. Everything is a part and parcel of TED spell or cyanotic spell.
Okay.
So cyanosis is different. If you are describing a spell, it might be associated with breathlessness, deepening of cyanosis, syncope, or seizures. So
Okay,
it's getting relieved by squatting. Squatting or
Squatting.
squatting equivalent, right? Some drugs
Knee chest exercise.
might be yes, yes, squatting or squatting equivalents. Yes,
Yes,
good.
yes.
Yes. Okay, man. Okay, man. So you are saying history of recurrent respiratory tract infection. Is there any
Yes, sir.
criteria to say recurrent respiratory tract infection? Then why do you ask this history specifically?
Recurrent respiratory tract infection usually occurs. Actually, it is usually occurs in left to right patients with increased pulmonary blood flow or pulmonary plethora, predisposing to infection, sir. It is typically defined as 4 or more infections occurring in a period of 1 year, sir. In a 1 year. That is recurrent respiratory tract
One or
infection.
more means upper respiratory tract infection or lower? Which one to be considered significant?
Lower respiratory tract infection, sir.
So if the patient is having warrants admissions and was treated with antibiotics IV means to more than 2 episodes pneumonia. So
Okay,
even outpatient more than 3 episodes of LRI or more than 4 or 6, there is no clear-cut guideline saying recurrent respiratory
yes, sir.
infection, but
Okay, sir.
it's a norm. Whether the patient warrants admissions at least 2 times a year for pneumonia or respiratory infection purpose, you can very well consider as recurrent respiratory infection. So yes.
Okay, sir.
So,
Okay.
but you are already made a diagnosis of ASD. That's why you are asking all this history. I think cyanotic spell, recurrent respiratory infection. But if you are going in as a proforma, so 50-year-old female coming with an LV dysfunction of 1 month duration, acute LV dysfunction, associated RV failure symptoms. So you might not ask all these cyanotic spells, RRTA, right?
Yes, yes, yes.
Okay, man. Next, voice change, hoarseness of voice. Why did you ask all these history? Dysphagia.
This could occur in valvular heart tissue lesions like MS causing lactated enlargement leading to compression of the rectilinear nerve or to compression of the esophagus leading to voice change in dysphagia, sir. Any tubular valvular heart disease etiology, sir.
Okay, okay. Okay, okay. Next slide.
Yes, sir.
So past history, as patient is having known case of congenital heart disease during 4th pregnancy. So at what was that age? Maybe in 20s or 30s?
She was around 30 years, 35 years. Sir.
35 years, first 3 pregnancies, she was not diagnosed to have any congenital heart disease. So, did you mention about her obstetric history? What was the mode of delivery? Everything did you mention?
Yes, yes, sir.
So,
the next slide.
In this slide, you have mentioned as 4th pregnancy, she was diagnosed with congenital heart disease, but she is on treatment since. What sort of treatment she is currently on?
She actually said she is on treatment, sir, but actually she is not on specific treatment for any. She did not have any proper records, sir. She just had just symptomatic tablets like paracetamol and B complex tablets, sir. No proper treatment or follow up regarding that is present in the records, sir.
Then you might have avoided this line, no?
Okay,
He is on treatment since. So, in what sort of what would be the treatment for ASD, VSD, or if at all, if it's a PDA or a TOF? If at all, TOF means she might be on some drugs, but ASD, VSD, PDA, or left to right shunt, any other congenital heart disease?
No specific.
Oh yes, yes, very less likely to be on medical management for all these years, since 30s to up to 50 years, right? Yes.
Yes, sir.
Okay, okay. So show me that obstetric history, but that natal history. Next one. Yeah, family. So obstetric history. All 4 are normal vaginal deliveries.
Yes, sir. Out of which 3 of them were institutional deliveries and 1 was home delivery, sir.
Okay, so that last 4th pregnancy only, she was diagnosed as some congenital heart disease.
Yes,
what sort
yes,
of congenital heart disease could she able to tell in the form of I'm having a hole in the heart kind of or
She
valve?
just told she had a hole in her heart, like that
Yes,
she told.
mostly patient will reveal this statement. I'm
Yes,
having
yes.
one hole in the heart, like, so we can very
Yes.
well say, so kind of
Yes,
some subtle defect. So patient clearly
yes,
says the diagnosis. So no headache for you or me, right? So patient
yes,
herself is telling the diagnosis.
yes.
So family history, okay, personal history. So that's all. Is there any other history you want to add here?
Mm.
So what is the history you need to ask if at all is a associated congenital heart disease? What is congenital? What are perinatal infections from her mother? So this is the index
Yes,
patient
yes.
from
Yes,
her
sir,
mother.
yes.
If she contracted some perinatal infections, she might have developed all these.
Yes, sir.
Uh,
Torch infections.
yes. So you need to ask what is the history you need to ask from her mother.
Um, if her
So
if
any
her mother had
exanthematous,
any infections,
any exanthematous fevers, right? So
exanthematous. Yes, sir.
exanthematous illness. So for example, rubella. So how will you elicit the history of rubella from her mother? So if anybody, if you want to ask some history, from the history, if you want to rule out rubella means what would be the history? Fever will be there, okay.
Fever
Then
with
fever with rash.
rash, sir.
Then what is the classic add-on one? Fever, rash. Then one more thing. In a case of rubella, lymphadenopathy.
Lymphadenopathy. Yes, sir.
Lymphadenopathy. So that is
Yes,
the
sir.
most differentiating point compared to other one. So
Okay, sir.
chickenpox or measles. So this is the classic
Yes, yes.
lymphadenopathy.
Yes,
So you
yes.
can very well ask this history. So
Yes, sir.
all these perinatal infections which are causing congenital heart disease in a newborn or whatever child means first trimester infections. So you need to
Yes, yes.
specifically ask about first trimester exanthematous illnesses.
Okay.
So then drugs. Some drugs, offending drugs might have produced teratogenic effect. So
Yes,
what are the drugs you need to ask? You've already asked one. Yeah, you not mentioned anything. What are the drugs history you need to ask from her mother? So because you are dealing with the congenital heart disease,
yes,
whether it's a 50 years or 20 years, that's immaterial.
yes, sir. Any lithium can cause Epstein's anomaly, sir. Or it could be any anti-epileptic system. First, most we should rule out, sir, like peritime
Yes.
or valproate, sir.
So for Indian setup, so you are correct. But in Western literature, everyone is concerned about fetal alcohol syndrome. So alcohol intake.
Yes,
So
yes,
during
sir.
first trimester, if mother is taking alcohol means, so most likely to have ASDs
Yes,
in
yes,
offsprings. Yes. So alcohol history from the mother. Then anti-epileptic drugs and other offending drugs, we know that, right? So
okay,
you need to ask, add this history also.
yes, sir. Okay.
Okay. So good. Next one. So this is a summary. So from this summary, so what is your provisional diagnosis, or could you make a differential diagnosis? So this is a 50-year-old female, known case of congenital heart disease. She herself revealed she had a hole in the heart, like
Yes, sir.
congenital heart disease. So hole in the heart means ASD or BSD.
Yes, sir.
Yes. So ASD or BSD. So she was asymptomatic for all these 50 years. She developed class 3 symptoms of 1 month duration. So what do you think? What is your diagnosis?
Most probably this would have been a atrial septal defect because without correction, a patient congenital heart disease with a hole in the heart, most probably which could have survived till now could be only a atrial septal defect, sir. Unless and until if would have any correction has been done, like if she had any previous surgery, then we could consider other differential diagnosis, sir. But she has no past history of corrective surgeries done for any congenital heart disease, sir.
Okay.
So if we don't consider this congenital heart disease differential diagnosis, then all the other differential diagnosis could be arrived, so like anemia or CAD or other differential diagnosis.
So from the history, you are saying congenital synovial heart disease or asynovial heart disease? First one. From the
Congenital
history.
cyanosis.
So from the history,
Yes.
asynovial heart disease. So left to right shunt
Yes, sir.
or right to left shunt. What is the specific history which says left to right shunt in this patient? Is there any history here?
There is a failure features has been present, sir. If it is left to right shunt per patient in an age, if it's an ASD, initially they will develop right heart failure followed by congestive cardiac failure. And if it would have been a VSD, the patient would have first initially developed left heart failure followed by congestive both sides heart failure, sir. So the failure feature is a supporting evidence that it is left to right shunt. And if it have been a reversal, there'll be other history elicitables like cyanosis would have developed following the patient has been initially normal, followed by developing new onset cyanosis or any clubbing could have been present, sir. But that is not elicited in history, sir.
Okay. So from the history, we can't say itself. There is no specific history like cardiac failure symptoms during infancy or childhood or even during adulthood, even during pregnancy, she was diagnosed. But you could not say much about even the fourth pregnancy events. So whether she was admitted in ICU, she was treated with any anti-failure measures, or was treated with ventilator support. What is there anything was needed
No,
during
sir.
that time?
Pregnancy and delivery
So,
was uneven.
yeah, uneven full delivery, the normal vaginal delivery. So she was incidental finding like or small acceptable kind of ASD might be there, right? So, so if at all it's a VSD, the patient might have developed symptoms in the earlier itself. Why? Why the ASD is asymptomatic all these years? Why VSD produces symptoms much earlier?
Sir, initially in ASD, the patient develops only right atrium, right ventricular enlargement, sir. So patient in VSD, the shunting which occurs is a large volume, sir, compared to ASD, sir. And there will be earlier fall in the pulmonary vascular resistance. In VSD, there is an earlier onset of pulmonary arterial hypertension developments compared to an ASD patient, sir. In ASD, the patient, if it is an example, if it is a normal uncomplicated ASD, only around the age group of around 30 to 40, they will develop these features, sir.
Why is it so? So regarding the left to right shunts, we know that there are three lesions: PDA, ASD, and VSD.
And
right?
VSD, yes, sir.
So this is not a rule of thumb. It's a common saying. PDA comes in the first decade. VSD usually manifests in the second decade. ASD usually manifests in the third decade. This is a common saying. This is not a rule of thumb. That there are obviously it's a common thing, right? So why this means? So in the PDA, the shunt is happening at the great vessel site. So there the pressure difference will be huge. So the highest pressure in the aorta, from the aorta, it's having connection into the pulmonary. So pressure that the shunt happening between these two great vessels are very much high. So even the pulmonary tolerance also it's poor during infancy. So patient will be symptomatic during the first decade itself. So in VSD, the shunt is happening between the ventricles. Here, the pressure between these two are relatively low compared to that large vessel shunt. Compared to PDA, the shunt pressure is low, but compared to ASD, shunt is obviously higher. So here the symptoms usually develops in the second decade. But in ASD, the connectivity or the shunt is happening between two low pressure chambers. Literally, there will not be any pressure gradient at all. So left atrium and right atrium both are in the same pressure. So even though there is a defect, the symptoms happening only because of compliance effect. So if RV is compliant, the patient will not be having any symptoms. If RV is less compliant, obviously the patient will develop symptoms. So it takes much years, right? So you are saying from the history, you are making only one diagnosis here. Or could you offer any other differential diagnosis? Only you are saying atrial septal defect.
From the history.
Okay, ma'am. So obviously, so nobody can't think any other than ASD from this history because the patient herself reveals I'm having a hole in the heart, right? So 50 years until now asymptomatic, so only symptoms developing during this age. So I do agree there could not be any other differential diagnosis other than ASD from the history. But I may not consider ASD as the only possibility here. As a clinician, you need to, because the patient is developed symptoms for the 1 month duration. So some arrhythmias or some associated coronary artery disease has to be ruled out. Yeah, in addition to your valvular or congenital acyanotic heart disease. So we can very well say the patient is saying whole means so only ASD. If the patient not using the term only having congenital heart disease means we can say bicuspid aortic valve. So one of the possibility congenital heart disease, aortic congenital heart disease, mitral valve prolapse or mitral valve congenital heart disease. There are so many lesions we can think. But the patient is saying the acyanotic patient is already acyanotic, no history of cyanosis. Only hole in the heart. That's so only we are narrowed down to ASD and VSD. From this history, we can say because of the patient is asymptomatic in all these years, we can narrow down to ASD. So ASD, but the catch here is associated some triggers like arrhythmias or coronary artery disease or infections or anemia or associated thyroid abnormalities, anything. Some hyperdynamic circulation might be or renal failure or whatever. Might be forcing the patient to land up in IP stay because for the past 1 month, right? So you need to consider. So we can check all this in your examination.
Yes, sir.
Okay, super. Okay, Shankar.
Yes, sir. I'll proceed to the examinations. General examination after obtaining consent from the patient. General examination, the patient was conscious, oriented, afebrile, thin built. There was no pallor, no uterus, no cyanosis, no clubbing. Bilateral pitting pedal edema was present. JVP was elevated. Hepatojugular reflex was present. There was no lymphadenopathy. No markers of any congenital heart disease. No markers of any infective endocarditis, or no markers of any acute rheumatic fever. No markers of TB or HIV. No markers of syphilis. Vitals. Pulse rate was 89 per minute, regular in rhythm.
Shankar, 1 minute.
Yes,
in the general examination, try to say thin rather than a thin build. Try to say BMI.
Yes, sir.
So then always in a congenital heart disease or any heart disease or any case, as a PG point of view, you need to look for morphinoid habitus. So in general examination, you need to arm span, height, upper segment, lower segment ratio, other features of morphine. So because you are presenting a case of congenital heart disease. So
I've added in the subsequent.
Subsequently. So, okay, man. Then okay. Then one more thing. You have mentioned as hepatojugular reflex. So, do you think this slide spelling is correct, or do you want to change the one? I'm saying this hepatojugular reflex is some spelling mistake is there. Are you agreeing with me?
Yes, sir.
Which one? So it's colloquially it's being described as hepatojugular reflex, but it's not a reflex.
Okay.
It's a reflex. REFLUX.
Sorry, sir. Yes, sir. Yes,
Every
sir.
textbook is being given as REFLUX, but
Yes, sir.
as an oversight, we are making it as reflex,
yes.
right?
Yes,
So
sir. Yes, sir.
could you say what is positive hepatojugular reflex?
Normally in a patient, we have to make the patient lie in a 45-degree head and elevation, sir, and turning the head to the left side. We have to on a normal patient, when we give an abdominal compression in the right hypochondrial region, there will be a transient rise in the JVP, sir. Around 3 centimeters alone will be present, which will be transient for around 10 to 15 seconds, and it will then become normal, sir. It is specified to be positive when there is a sustained response of elevation of the JVP to this maneuver, sir.
Yes. So some book says it's you need to give firm pressure over the right upper quadrant. So if at all the patient is already in right heart failure, congested liver, if you are giving pressure over the right upper quadrant, the patient will be
Aggravated failure.
patient will be wins with pain. So
Yes,
you
sir.
need to avoid putting pressure directly over the liver area. So you can give
Okay,
pressure over the central abdomen.
Okay, sir.
So here, when to say hepatojugular reflex is positive means the pressure should be more than 3 centimeter JVP elevation, but it should be sustained more than 15
Yes,
seconds at least, right?
Yes, sir.
So
Yes,
either of these two criteria is met, you can say its hepatojugular reflex is positive. Good.
Yes, sir.
So
Yes.
what are the conditions associated with positive hepatojugular reflex?
Right-sided heart failure patients will have a hepatojugular service, or it could be any case of tricuspid regurgitation.
Yes.
You can have a hepatojugular reflex.
Yes. Okay. Good. So then, what are the markers of congenital heart disease did you look for in this female?
Congenital heart, like from top to bottom, we could look for any facies, typical mongoloid facies, any epicampal folds, or if the patient has a large protruding mouth, uh, low set ears, low posterior hairline, or pectus cavitatum or pectus excavatum, simian crease, or even a shield like this, or patient have other features like saddle gap between the first and the second toes, or pescavus, or other features with presence. These are some of the markers of congenital heart disease, which you see on external examinations.
Okay. Well, then, what are the markers you look for infective endocarditis? So in examination, if somebody asks me what is hypertelorism, you need to say. So what is the criteria to say hypertelorism? What is the criteria to say high arched palate? What is the criteria to say webbed neck? So when to say that short stature, when to say that patient is obese, whatever. So everything, all criteria you need to.
Yes.
Yes. What are the markers of infective endocarditis?
Patient could have splinter hemorrhages, anemia. The patient can have Janeway lesions, osseous nodes may be present, sir. Patient infected endocarditis, or in a fundus examination, we could look for rot spots, sir.
Okay.
Arthritis, secondary.
Okay. Then where do you look for the marker of syphilis? What are the markers of syphilis you look for in a female?
Markers of tertiary syphilis you can look for, sir, like rugged prominent facial features, or patient will have gummatous lesions.
Okay. So have you checked for cyanosis? If at all, if the patient is having cyanosis, fingers and feet,
Yes, sir.
toes and fingers. So,
Yes, sir.
what sort of cyanosis would you name? Central cyanosis or peripheral cyanosis?
Toes and fingers alone means we usually peripheral cyanosis, sir. But if
But
central
in
cyanosis,
central
we should.
cyanosis, you will not get cyanosis over the toes and fingers, right? Abhya. Are you sure?
Yes, sir.
No. This you just concept is slightly need to be changed, right?
Okay, sir.
So, in peripheral cyanosis, you will not get cyanosis in the well-perfused areas like tongue and buccal mucosa. But in central cyanosis, you will get cyanosis in both in fingers and toes, tip of the nose, in ear, whatever, including well-perfused areas. So, so in central cyanosis means the patient will be cyanosed only in the tongue and oral mucosa. So central cyanosis means peripheral cyanosis plus well-perfused areas. So some clarity I'm just telling you. Okay, next.
Pulse rate was 89 per minute, which was regular in rhythm, normal volume, no specific character, no radial or radiofemoral rate, felt equally in all peripheral parietal vessels. Blood pressure, which was measured, right upper limb 110/60, left upper limb 100/60 millimeters of mercury, right lower limb 120/70, and left lower limb 110/60. Respiratory rate was 19 per minute, regular in rhythm, thoraco-abdominal type. Temperature was 98.6 degree Fahrenheit, and JVP was around 7 centimeters above the sternal angle at 45 degree recommended force pressure. Saturation was 98% in room mass. Anthropometry, the height was around 154 centimeter with weight being 45 kg, and BMI was calculated to be around 18.9. Arm span was 156 centimeters, and arm span to height ratio was around 1.01. Upper segment was around 75 centimeters, and lower segment was around 79 centimeters. Sir. And upper segment to lower segment ratio was calculated to be around 0.9. Sir.
Okay. Okay.
I will.
So this patient is having JVP elevated.
Yes, sir.
So could you make out any waveforms? So if JVP is normal means you need not to say any waveforms. If it is elevated,
yes, sir.
You should be able to at least, is there any positive waves, whether A is permanent or something like?
I was able to discern A waves, sir. And A wave and A wave prominence was seen, sir. Other I could not delineate properly, sir.
How to check the waveforms, whether this wave is A wave, whether this wave is a C wave, how to make a wave? There are 3 positive waves and 2 negative waves, right?
Yes, sir.
How to say how are you saying whether this wave is A wave? Some wave is prominent, one positive wave is prominent. That might be A or C or B. Yes.
Carotid, we have to calculate for the opposite side carotid, and we can time based on the timing of appearance of the wave in relation to carotid, which usually coincides with S1. With that,
so
we
which
can
JVP wave coincides with S1? Which comes before S1?
A wave will be coming before S1, sir.
Yes. So
A wave X wave will come after S2, sir.
So A wave comes before S1. Yes. C waves coincides or just follows S1. Then comes the descent, X descent. That comes between S1 and S2 because it's X descent means it's atrial relaxation, right? So then V wave. V wave comes just after S2. So we usually say it's after S2. So because of venous filling of right atrium. So at least you could able to say A wave, C wave, V wave. At least positive waves you need to say whether. So mostly if JVP is elevated because of pulmonary RV failure, whatever. So A wave will be prominent, right? So you can very well make out because the patient is having atrial fibrillation, A wave will be absent. So
Absolutely. Yes,
from
sir.
this we can differentiate.
Yes, sir.
Okay, ma'am. So always, if at all JVP is elevated, try to say waveforms.
Specify the rates. Yes,
Okay, okay, Shankar.
sir. Yes, sir.
Good.
Next, I'd go like to systemic examination, the cardiovascular examination. On inspection, the trachea appears
One
to
minute,
be.
Shankar. 1 minute.
Yes,
1
sir.
minute. I need to check whether Suresh has joined or not.
Yes, sir.
Yeah, he has joined, I think.
Yes, sir.
Sir, Suresh, sir?
Yeah, I can hear you. Go ahead.
Then okay, sir. Okay, Shankar. Sir, shall I ask PG to summarize the history and until this, sir?
If possible, okay.
Better, sir. Just I will make him. Shankar,
Yes, sir.
cardiologist has joined.
Yes, sir.
Just
Yes,
please read the summary slide at least. Yes.
Yes, sir.
Okay.
Good evening, sir. A 50-year-old female who's a daily wage laborer coming from a low socio-economic background was a known case of a congenital heart disease presented with complaints of progressive exertional breathlessness, which progressed to NIHA class 3, currently associated with paroxysmal nocturnal dyspnea, orthopnea, with bilateral symmetric pedal edema and easy fatigability. The probable system which was involved is the cardiovascular system and this summary.
Shankar,
Yes, sir. Yes,
Shankar,
sir.
can you hear me?
Yes, sir.
So why do you say it is cardiovascular? Can the same symptomatology can happen in respiratory also? In what symptomatology, with regards to what symptom you are differentiating this from respiratory?
Sir, the patient has symptoms associated with postural variation like orthopnea and paroxysmal nocturnal dyspnea, which typically points to the involvement of the cardiovascular system.
So to differentiate from a respiratory, you need to have left heart involvement. This is very
Yes,
classical.
sir.
The patient is having PND and orthopnea. Both suggest the patient is having left heart involvement. So whenever
Yes,
there
sir.
is left heart involvement, you have to point towards the cardiovascular.
Yes.
So respiratory, you won't have this left ventricular involving symptom like PND orthopnea. So the PND orthopnea
Yes.
both are differentiating respiratory from your cardiac. Okay,
Yes, sir.
because if it is not there, all other symptomatology can happen very well in respiratory system also.
Respiratory.
Okay,
Yes, sir.
so
Yes,
these
sir.
two important symptomatology always points towards cardiovascular from respiratory because both are the close associated systems where it is difficult for you to differentiate. So whenever there is a PND or whenever there is orthopnea or whenever there is a left heart symptom suggests your left heart involvement, it is pointing towards cardiovascular system. Okay,
Yes, sir.
yes.
Yes.
So the patient is 50 years old female.
Yes, sir.
Okay, when did she start developing breathlessness? At what age she started developing breathlessness?
Actually, around only past 1 month, she had a history of breathing difficulty, sir.
So
And the
49
bilateral
years,
swelling of
49 years, he won't have any symptomatology.
sir. Mm.
Shankar, the age
Yes,
of the
sir.
patient is 50. Am I right?
Yes, sir. Yes, sir.
So as per your history, only 10 days old. History, symptomatology is only for 10 days.
1 month, sir. Breathing difficulty for 1 month.
Okay, 1 month. Okay.
Yes, sir.
So
It has
till
been
then,
progressed.
before that, patient didn't have any symptomatology?
No, sir.
No.
Yes, sir. No, sir.
See, so as per your history, it is looking like a acute to subacute. Am I right? It is not a chronic
Yes, sir.
disease. It's only 1 month old.
Yes, sir.
So in a patient presenting started a congenital heart disease, it is very difficult to have a acute symptomatology. Otherwise, there are very rare cases. So if you want to put a chronic cause, always will be the first one. Okay.
Yes.
Probably
Okay, sir.
patient may not notice the symptomatology or it is difficult for you to extract the symptomatology. Patient might have symptomatology for at least 1 or 2 decades if it is from a congenital heart disease. Okay.
Okay, sir.
So
Okay, sir.
probably patient may not aware of the facts. Okay.
Oh, okay, sir.
Okay. So these are the symptoms for only 10 days. Okay.
Yes, yes, sir.
Okay. Go ahead.
Yes.
Go back. Shankar, go back.
Yes, sir. To
So
which
you told JVP is elevated and you have put hepatojugular reflex. Both are in the same slide. Is it correct?
um,
You are contradicting your own point. What is the inference you get from JVP elevation?
Hepatojugular JVP elevation tells us that the patient is having a right heart failure, sir.
Very good. So JEP elevation told the patient is having overt RV failure. What is hepatojugular reflex? Positivity says what?
Actually, hepatojugular reflex helps us in it's an earlier sign of right heart failure, sir.
So it is not an
Unless
earlier
until
sign, it is an
the
incipient RV failure. It's a sign of
yes,
incipient
sir.
RV failure. Where
Insufficient. Okay,
JVP
sir.
is overt RV failure. If there is a overt RV failure, there is no need to put this hepatojugular reflex.
Okay, okay, sir.
Okay, you are
Okay.
strongly suspecting RV failure, but you don't
Yes,
have
sir.
any JVP elevation, then you have to do an hepatojugular reflex to say
Okay, sir.
the patient is having incipient RV failure. So once the
Okay, sir.
patient is having overt RV failure, there is no need to put this one. Okay, so take
Okay,
out
okay, sir.
hepatojugular reflex positive because it should be
Okay,
there.
sir.
And more
Okay, sir.
importantly, in any JVP, you have to tell two things. JVP,
Mm.
pulse and pressure for waveforms, both you have to tell. Okay. So
Okay,
JVP
okay,
is
sir.
elevated how much, and you have to tell the waveforms. And it is the and you have to tell the third important point. What is the respiratory variation of JVP? In any
Yes,
JVP, you have to tell whether pressure is elevated, what are the waveforms seen, and more importantly, what is the relationship to the respiratory variation. These three things to be said in all JVP. Okay.
okay, sir.
Yes. Yes. Yes.
Yes, sir. Shall I proceed to the next slide, sir?
Yes. Yes. Go ahead. Go ahead.
Yes. Thank you, sir. I would like to proceed further to the cardiovascular examination. On inspection, the trachea appears to be in the midline. Shape and size of the chest wall appears to be symmetrical. Apical impulse was not visualized. Parasternal pulsations were seen. No precordial bulge. Pulsations are seen over the parasternal area and the left second intercostal space. There was no kyphoscoliosis, no dilated veins, no scars or sinuses over the chest walls.
The parasternal pulsation scenes in the second to fourth intercostal space or any specific area. You told one is left second intercostal space. Is there any other area left lower sternal border or whole parasternum right or left?
Around the left and second intercostal space and third intercostal space alone it was present, sir.
Okay. By saying left second and third intercostal space, anatomically which area you are telling? It is related to which area in heart? Because in parasternum, each and every area related to something. Some is related to RV outflow, some is related to RV body, something like that. So each and every space related. So for example, if it is left second intercostal space, it is related to, you are pointing out pulmonary artery.
Pulmonary area,
Okay. So
pulmonary
right,
area,
pulmonary
sir.
area.
Yes,
Like
sir.
that,
Yes,
third
sir.
and fourth is something like that. You have to know that.
Yes.
Okay.
Yes, sir.
So as per your statement, second, third, and fourth, third, both are having pulsations. Okay.
Yes, sir. Yes, sir.
Yes.
On palpation, the trachea was confirmed to be in the midline. Apex beat was felt in the left fifth intercostal space, 1 centimeter lateral to the midclavicular line. Was hyperdynamic in nature. Grade 2 left parasternal heave was present. There was a palpable P2 in the left second intercostal space and a systolic thrill present in the pulmonary area. There was no tracheal tuck present.
Okay, Shankar, you told it's hyperdynamic in nature. Okay.
Yes, sir. Yes, sir.
So normally hyperdynamic apical impulse will happen in which conditions?
Hyperdynamic apical impulse occurs in high output cardiac states or any volume overload conditions causing lesions like aortic regurgitation or mitral regurgitation
So
or
what will go ahead. What will
and
happen
then
to the apex beat in these conditions? It is only direct, as per your statement, there is only lateral shift. There is no downward shift. So in
yes, sir.
hyperdynamic conditions of heart, there should be both down and out.
Downward and
Actually,
outward,
downward
sir.
shift should be there. Is there
Okay,
any
sir.
condition where there is only a lateral shift with hyperdynamic in nature? You are telling like that. Am I right?
Yes.
Is there any condition like that?
No, sir, usually pressure overload. No, it could be 1 centimeter.
That's what I am saying. You are contradicting your
yes,
own statement. If it is
okay, sir.
pressure overload, it can have a lateral extension.
Yes, sir.
Hyperdynamic usually both
Outward
down
and
and out.
downward.
It should be laterally
Yes, sir.
shifted as well as downward shifting. Both should be there. Am I
Okay,
right?
sir. Yes, sir.
So I don't think so. This point is. Did you examine correct properly?
Yes, sir. Yes, sir. It was a hyper kinetic. I'll change the statements.
Okay, but both
Yes,
will not happen. It should be at least
yes, sir.
downward. There must be somewhere
Okay, sir.
downward shift also. Okay,
Okay,
correct
sir.
yourself. Okay,
Yes, sir.
no problem.
Yes.
So other things are pointing towards the pressure overload. See, grade 2 left parasternal heave, palpable
Yes, sir.
P2, everything points towards the pressure overload. Okay.
Yes, sir. Yes, sir.
So as
Yes,
per
sir.
the thing is one, so what could be the cause for the lateral shift of apical impulse with these findings?
It could be because of a right ventricular enlargement, sir.
So right ventricular hypertrophy will push the
Okay,
apex towards lateral. So in
yes,
the
sir.
case of severe MS where you can have RV enlargement and rotation causes left ventricle to go posterior, like that it can happen. That's the only way.
Yes, sir. Yes,
Okay.
sir. Yes, sir.
Yes, yes, yes. So always once you write everything, recorrect your findings. Okay.
Okay, sir. Yes, sir.
Yes.
Yes, sir. On percussion, right heart border dullness was present 1 centimeter outer to the right sternal border, left heart border corresponding to the apex. A dull note was noted in the left second intercostal
What is
space,
the
sir.
name of that
Uh,
dull node? Is there any name for that?
dull, dull,
Okay, go and read.
no, no, sir. Yes. Auscultation. In the mitral area, S1 and S2 was heard. There was no any added sounds or murmurs. In the
Please,
tricuspid area,
wait. You have to
yes,
always
sir.
say S1, S2 and S3, S4. You complete
Okay,
all
sir.
the hard sounds. Then go for added sound and murmur.
Okay, sir.
Okay, S1, S2
Okay, sir.
head, both are normal. First you tell about
Okay.
S1, normal. S2,
Yes, sir.
normal with the normal respiratory variation. Okay,
Okay, sir.
there is no
Okay, sir.
S3, S4. You have to completely say everything. Okay, each and every point is having some hemodynamics. So you have to
Okay, sir.
say mitral area S1 head, normal. S2 head, normal with the normal respiratory variation. No
Okay,
S3, no
sir.
S4. And then go for added sounds and your murmur. Okay?
Okay, sir.
Yes.
Uh, in the tricuspid area, S1 and S2 was heard, and S3 and S4 was not present. There was a mid-diastolic murmur heard with grade 3, which was heard with the bell of the stethoscope, heard well during the expiration, sir, and, during expiration.
So
This
what
was
is
in the
Carvalho
tricuspid.
sign? What is Carvalho sign?
Right-sided murmurs like in tricuspid regurgitation, there on inspiration, due to increased blood flow, venous return to the right side of the heart, the murmur will increase in the intensity, sir.
Okay, yes.
Yes, sir. In the pulmonary area, S1 was normal. In the S2, there was a wide and fixed split S2 with a loud P2 component was heard, sir.
So why
S3
do
and
you say
S4
it
was
wide
not
and
present.
fixed?
Uh, there was fixed because there was no variation in both inspiration and expiration. And wide, this is a typical hallmark sign seen in an atrial septal defect, sir.
So
So
it is,
the hemodynamics associated with this that since it is a left to right shunt, from the left to right atrium and to the right ventricle, there is a prolonged hangout interval is present, sir, in the patient.
the prolonged
There will be
handout
an
interval is reason for wide, accepted. What is
yes,
the
sir.
reason for
Yes.
fixed?
Uh, already the fixed is because already in the both in the inspiration and expiration, the pulmonary capillaries would have already been filled and accommodating all the blood, sir. So during expiration, there will not be any variation present. So that's why it was
Is it the
fixed, sir.
answer? Is it the answer? Which produces P2? P2 closure is done by what?
Uh, P2 closure by the pulmonary.
So the amount of blood
Yes, sir.
reaching the pulmonary artery should be fixed with both an inspiration and expiration. So
Yes, sir.
the cycle that the shunt between left to right shunt and right to left shunt both can happen in inspiration and expiration because of ASD. So
Yes, sir.
whatever may be the shunt that happens during inspiration and expiration in ASD will be
Yes, sir.
nullified and the blood volume, the amount of volume blood reaches the pulmonary artery both in inspiration and expiration remain constant.
Okay,
Okay.
sir.
So because
Okay, sir.
during inspiration, normally what will happen? the blood from RV will go to RV, RA to RV will come. During
Yes, sir.
expiration, the blood from LA to RA, it will
LA
come.
to the
So,
ventricle. Yes, sir.
so both during inspiration and inspiration, if there is a atrial septum is intact, this changes will never happen. That's why
Yes,
in
sir.
inspiration, the P2 will become wider and A to P2 will become wider. In expiration, it will become narrowed because there will be left sided blood will not come to the pulmonary RV into the pulmonary artery. Because
Yes,
of
sir.
the shunt only, both inspiration and expiration, there is constant blood volume in the pulmonary artery. So that the
Okay.
closure of pulmonary artery is fixed.
Fix it.
So
Yes,
the
sir.
changes that happens in the ASD during inspiration and expiration will be recancelled or nullified by the shunt. So the amount of
Okay.
blood reaches the pulmonary artery. Subsequently, the occurrence of P2 will be fixed. Okay.
Okay, sir.
Okay. Yes.
And an ejection systolic murmur of grade 3 was heard with the diaphragm of the stethoscope, with the patient in the sitting and leaning forward posture with breath held in expirations.
Okay. Is it ejection systolic murmur means what you are telling? What is your inference by saying ejection systolic murmur?
Since it is heard in the pulmonary area, it could be because of the development of any pulmonary arterial hypertension, sir. Because of which we have a ejection systolic murmur occurring during the systole, sir, the
Okay.
pulmonary area.
Any ejection systolic murmur, it should be mid-systole in nature. There should be
Yes,
it should start after isovolumetric contraction. So it is
yes, sir.
mid-systolic in nature, and both
Okay.
it has a kite shape that is crescendo
Crescendo
decrescendo, and
decrescendo.
more importantly, it arises from the corresponding ventricle into the corresponding artery. Okay, light in RV to pulmonary artery. So by
Yes, sir.
saying like that, you can have two diagnosis. One is either valvular stenosis or your pulmonary hypertension. Both can have
Yes,
a
sir.
ejection systolic murmur at pulmonary area, but
Yes, sir.
there may be a difference between both these two. Okay, so
Yes, yes.
ejection systolic murmur, if you want to, if you are describing, it is always these three characters should be says, and if you are saying,
Okay, sir.
we are assuming that this is happening there, so it should
Okay,
be
sir.
mid systolic. It should be
Yes, sir.
crescendo decrescendo, and more
Decrescendo.
importantly, corresponding ventricle into the corresponding large corresponding
Mhm.
pulmonary arteries. Okay, ventricle to the
Yes,
corresponding
sir.
arteries. This should be there. Okay,
Yes, sir. Yes, sir.
okay.
Next, in the aortic area, S1 and S2 are heard, S3 and S4 was not present, and no added sounds or no murmur sounds. Sir.
Okay, okay.
I'll progress to other system examination. Respiratory system examination, bilateral aortic was present. Bilateral basal inspiratory crepitations were heard over the basal areas, sir. Her abdomen was soft with no organomegaly.
Is it mid inspiratory, late inspiratory, early inspiratory?
Mid to late inspiratory creps, sir.
So you have to specify that because each and
Yes, sir.
everything is having a value. Mid
Yes, sir.
inspiratory is bronchitis and late inspiratory is
Yes.
your alveolar edema, something like that.
Yes, sir.
You have to
Yes,
pinpoint.
sir.
Okay.
Okay,
Yes.
sir. And CNS examination, normal higher mental functions. There is no any associated neurological deficit present with the patients.
Okay.
Come to the diagnosis, sir. The probable is a case of an acyanotic from the history and the examination. A case of acyanotic congenital heart disease is probably a left to right shunt, probably being an atrial septal defect with evidence of pulmonary arterial hypertension and congestive cardiac failure in patient in normal sinus rhythms.
So why do you say it's a left to right shunt? What are the points towards to say the patient is having left to right shunt?
Sir, the patient is having a wide and fixed split of S2 in an ASD,
Start
sir.
always from symptoms.
His symptoms. The patient presented with failure features such as
Very good. All
breathlessness,
left to
chest
right
compressed,
shunt,
sir.
yes, yes. All left to right shunt have volume overloaded or failure symptoms. Right to left shunt will have pulmonary. This is called pulmonary plethora, otherwise
Plethora.
pulmonary overflow.
Yes, sir.
Okay, where right to left
Yes, sir.
shunt will have pulmonary oligemia.
Oligemia.
Right, or
Yes, sir.
pulmonary. So this is called decreased pulmonary blood flow or increased pulmonary blood flow. Congenital heart disease category should be, the physiology should be differentiated whether it is decreased or increased. For this
Yes,
case,
sir.
it is coming under increased pulmonary blood flow. Okay,
Blood flow.
so
Yes, sir. Yes, sir.
all the patient will develop with and the only thing is it is the age. Usually 50
Yes,
years,
sir.
that's the only thing. Yes, age is the
Yes,
only
sir.
thing. Okay, sorry. Left to right shunt, always the patient presents with failure symptoms. Whereas
Yes, sir.
right to left shunt patient presents with dyspnea, fatigue,
Yes, sir. Yes, sir.
hemoptysis, like that.
Yes,
They will
yes,
present
sir.
with other symptomatology, not with your failure symptoms. Okay.
Yes, sir. Yes, sir.
Okay.
Um,
Why do you say there is a
then,
pulmonary arterial hypertension?
uh, from the examination, sir, we could, on inspection, palpation, we could see the parasternal heave was present in the patient, sir, and a loud, and a palpable P2 was present, along with the in the ejection systolic murmur heard in the pulmonary area, and also we have an we have a right ventricular type of apex, which all denotes the patient to be having speeches suggestive of pulmonary arterial.
So, okay, everything is there. As per your statement, if the patient is having severe pulmonary arterial hypertension, will the shunt will remain left to right or it will go for right to left?
Uh, Even if the patient has pulmonary arterial hypertension, after a prolonged time only, there will be reversal and causing ACM embolization, sir.
So, as per your statement, even though there is a severe pulmonary hypertension, as per clinical examination, still the patient is having left to right shunt.
Yes, sir.
Okay.
Yes, sir.
What is the saturation? SpO2?
It was 98, sir.
90?
98%.
98. Okay. Okay. Yes.
Yes,
Yes.
sir.
Yes.
Yes, sir.
So there are two types of pulmonary arterial hypertension. First, three types. Two types. One is hyperdynamic pulmonary artery pulmonary hypertension, where there is
Yes, sir.
increased flow.
Yes, sir.
Reactive to that, the patient, the pulmonary circuit will go for vasoconstriction. That is called
Yes, sir.
hyperemic pulmonary arterial hypertension, where most of the time that is reversible. Still, the patient may have left to right shunt. But over
Yes,
a
sir.
period of time, that reversible vasoconstriction go for an habilitative changes. That
Yes, sir.
happens, the patient will go for a irreversible pulmonary arterial hypertension or habilitative pulmonary arterial hypertension, where the shunt will reverse into right left. Otherwise, that is
Yes, sir.
going for an Eason Mengerization. Okay.
Yes, yes, sir.
So, as per your statement, till it could be a left right shunt, because even though there is a severe pulmonary hypertension, there is a, a failure symptomatology is there. So, everything points towards, even though the pulmonary hypertension is high, still the patient is
Yes,
having left right shunt.
yes, sir.
Would you say congestive cardiac failure?
Uh, Patient has symptoms of paroxysmal nocturnal dyspnea with the orthopnea with the pedal edema present, sir. Along with
Okay.
that, even in the respiratory system examination, also we have fine bilateral basal, fine end inspiratory crepitations was present, sir, in the patient.
So congestive
This,
cardiac means that patient should have both congestion. It is
right,
systemic
yes, sir.
congestion
Fine,
as well as pulmonary congestion. Both
pulmonary
should be.
condition, sir.
Okay. So as per your statement, patient is having both congestion accepted.
Yes.
So what is the reason behind the patient is developing PND in this case?
Paroxysmal,
PND orthopnea, yes, both.
yes, sir. Paroxysmal nocturnal dyspnea typically occurs after 2 to 2.5 hours onset of sleep in the lying posture, sir, because of the increase in the intravascular compartment. The interstitial fluid comes into the intravascular compartment, leading to overload, which leads to increase in the venous return, leading to increased pulmonary venous pressure and increase in the pulmonary capillary wedge pressure, sir. And then during that time of sleep, there will be decrease in the sympathetic drive to the heart, due to which it precipitates the symptoms, sir, of paroxysmal nocturnal dyspnea.
So this holds good for
And
orthopnea also. Why there is some
yes,
difference between the time?
typically it occurs during the REM sleep.
Orthopnea
Uh,
also remains same. Then both are the what is the difference?
Sympathetic drive is the main cause during sleep. Sympathetic drive could be reduced, leading to the symptoms.
So most of the time, both are the mechanism behind both orthopnea and PNDs most of the time remain same. There are
Yes,
subtle
sir.
difference. One or two difference is very important. One is the time
Okay, sir.
accepted.
Yes, sir.
The patient develops an PND after half an hour to 2 hours of sleep. More
Yes, sir.
importantly, in orthopnea, the patient develops symptomatology immediately lying down. And
Yes, sir.
importantly, the patient will relieve of symptom once he sets up. Okay, so that
Yes,
is
sir.
orthopnea. But where in the
Yes, sir.
case of PND, the development of symptoms takes time. Same vice versa, the relieving of symptoms also take at least half an hour. It is
Yes, sir.
equivalent to
Yes,
one
sir.
pulmonary edema, acute pulmonary edema. So PND is always worse. One thing. And the
Yes, sir.
other thing is PND is a sign of failing heart and orthopnea is a sign of failed heart. By saying like
Okay, sir.
that, there is a pulmonary venous capacitance are always there. In the case of
Okay.
orthopnea, the pulmonary venous capacitance is already completed, already overloaded, already fulfilled. So there is no
Yes, sir.
amount, even 10 to 15 ml of blood can be accommodated in the pulmonary capacity with venous capacitance because it is already overloaded. So nothing, even a 10 ml blood cannot be accommodated. So the patient develops symptomatology immediately. Whereas in the case
Okay.
of PND, there is some amount of pulmonary venous capacitance is still there. So it can accommodate
Yes, sir.
some amount of blood still. So that
Yes,
is
sir.
the two reason. One is slow redistribution of fluid from the interstitial into the intravascular compartment. It takes some time. Another thing is some amount of pulmonary venous capacitance still there. So these are the two
Yes, sir.
reasons why PND develops later. And these are the two
Okay, sir.
reasons why it is relieved slowly also. Because it has to relieve slowly because the vascular redistribution occurs very slowly.
Yes, sir.
Okay.
Okay.
Okay, with the patient, it's normal sinus rhythm.
Mm.
Okay, okay. Do you have any investigations supporting to your diagnosis?
Shankar,
Sir. Yes, sir.
1 minute. So you mentioned one murmur in the tricuspid area, right?
Yes, sir.
So what would be the reason for that murmur in the tricuspid area?
Sir, in the tricuspid area, the murmur could be because it could be a flow murmur, sir, because
Okay.
of the flow via the tricuspid area
So
compression.
that should be your explanation for left to right shunt. So if at all
Yes, sir.
right to left shunt is happened, so there will not be any flow murmur across the tricuspid valve. So this
Yes, sir.
patient is having left to right shunt, so
Yes.
increased flow across a normal tricuspid valve, so you are getting a flow murmur.
Yes,
So
sir.
if at all Eisenmengerization happened, so tricuspid, the flow murmurs, the TS flow murmur will not be there. So,
Yes, sir.
this gives one add-on point for your left to right shunt.
Yes, sir. Yes, sir.
Yes, yes, yes.
Yes, yes, yes.
Okay, Shankar, good.
Yes, sir.
Sir, can I add one more
investigation
point, sir?
Yes,
Please, sir, please, sir.
Yeah, Dr. Suresh Kumar, sir, regarding the abdominojugular reflex,
Yes,
the
sir.
incipient right heart failure and the elevation abdominojugular reflex in the JVP examination, other than the points which you discussed, it's also useful for a person who's going to develop a cardiac cirrhosis, where we don't expect rise in the jugular venous pressure for sustained for more than 50 seconds after the pressure also created. Because of the cirrhotic liver, it won't transmit the pressure from the abdominal veins to the right side through the IVC and the right heart. So this is also another important point. Other than the incipient right heart failure or established right heart failure, going with further elevation of the jugular venous pressure can also note down absence of this, also pointing towards patient probably might have progressed from completely full-blown right heart failure into cardiac cirrhosis. There also you don't get positive jugular venous pressure, sorry, abdominal jugular reflex. That's also additional point you can add to that.
Yes, sir.
Okay,
Yes,
sir.
sir. Yes, sir.
Yes.
Please go ahead. Dr.
Okay, Shankar. Okay, sir.
Yes, sir.
Good, sir. Yes, sir. So cardiology sir asked for, Suresh sir asked
Yeah,
for
yeah, go ahead, man.
Investigations.
investigations. Yes.
Yes.
How
Yeah,
to we are
you
going
have any
to
investigations supporting your diagnosis?
Investigations, I would like to do a routine blood investigation, sir. Imaging wise, I would like to go for a basic electrocardiogram along with a chest X-ray, sir, and echocardiogram, trans thoracic echocardiography, along with, in some cases, even transesophageal echocardiography may be required, sir.
Okay.
And to see if any operability of the patient, we may need to do CAT studies for the patient.
Do you have echo finding here? ECG echo here? No.
Echo has not been still taken for ECG.
Okay. Do you have ECG? ECG? At least let's some discuss about
Yes,
ECG.
ECG image is actually in TR what itself I took the case and like sort of say.
Okay. Try to put because this
Yes, sir.
ECG, ASD
Yes, sir.
ECG very much classical for
Yes, sir.
your PG
Yes, sir.
postgraduates.
Yes, sir.
Okay.
Yes, sir.
So as per your statement, yes, you have to do everything. And if there is the only thing 50 years, usually
Yes, sir.
50 years the age group for the atrial septal defect. What
Yes,
is
sir.
the age group presentation of left to right shunt for VSD and PDA. Which is present earlier, symptomatology wise?
PDA is present earlier, sir. In the first decade, second decade VSD, and later atrial septal defect.
Why PDA is more earlier than VSD?
Because of the pressure gradient occurring between the shunt is more significantly higher in PDA compared to VSD and ASD, sir.
Is it the answer or something else? You are partially correct.
Significant
RV is
pressure gradient
exposed to
occurring
the
between the yes, sir.
in PDA, the RV is exposed to the increased blood flow both in systole and diastole. But in VSD only in systole. Okay,
Yes,
so
sir.
both
Yes, sir.
cycles it will happen. So the PDA
Okay, sir.
occurs earlier, whereas Eisenmenger it is one. Sorry, VSD will be 1 decade later because the
Yes,
pressure
sir.
difference or the shunt is both present in systole and diastole because of PDA. Okay.
Yes, sir.
So
Yes.
patient presents earlier. Okay. So the other
Okay.
symptomatology, this left to right shunt, always the patient failure. These two entities, whether VSD and PDA, will have symptomatology in the first decade itself, not this ASD where you have symptomatology of fourth or fifth decade.
Yes, sir.
Okay. Then can
Yes, sir.
you tell some causes of atrial septal defect which can go for pulmonary hypertension earlier? First decade, second decade, like that. This is fifth decade. This is a typical presentation of an ostium secundum ASD. Accepted. Is there any
Yes,
entity
sir.
where you have ASD with the severe pulmonary hypertension earlier?
Gluten-bar production.
Otherwise, ASD with Eisen memorization earlier.
Eisenmenger, sir.
Hmm.
Yes, sir.
Complete AV canal defect.
Okay, sir.
Okay. ASD
Yes, sir.
with the Down syndrome, where
Yes,
you
sir.
will have
Endocardial
bronchopulmonary.
cushion defects.
Yeah.
Yes, sir.
And
Okay,
ASD
sir.
with the primary pulmonary hypertension. These are the entities
Okay,
where the patient presents earlier than this.
okay, sir.
Okay, and this is the cause for why the patient with the ASD with the cyanosis, left to right side with cyanosis. Is there any possibility?
In a
Yes,
sinus
yeah,
venosus
it
type of
in
ASD, we can get this, sir.
sinus venosus. Anything else?
Unroofing of the uh, roof of the coronary sinus, or when there is a left SVC, sir. In
Okay,
such a
then
condition, there will be cyanosis with the left direction.
anything yes accepted. Anything else? Anything more?
Uh,
What is the relationship of Eustachian valve? Eustachian valve in IVC, something like that. Is there anything like that? Coronary sinus type of coronary IVC type of ASD. Okay, you go ahead and
okay.
just read. These are
Yes,
the
sir.
causes. You
Yes,
may be asked about cyanosis in ASD and earlier
yes, sir.
pulmonary hypertension in ASD. This may be the this you may be asked in between whenever you present any
Okay, sir.
case.
Okay, sir.
Okay.
Shankar,
Yes, sir.
just one small question related to ECG.
Yes,
So
sir.
usually we are saying ASD with ostium second time, say OS type, will be having right axis deviation.
Yes, sir. Yes.
But in ostium primum type, left axis deviation. Why is it
Yes,
so?
sir.
Could you able to tell me the reason
The
behind this?
ostium primum atrial septal defect are usually associated with endocardial cushion defects. There may be associated mitral regurgitation. So in such cases, there can be associated left axis deviations, sir.
Mm-hmm.
Telling the facts, but you didn't tell about the reason. Sir is asking why there is left axis deviation.
Yes. Ostium secundum, right axis deviation, RBBD. That ostium primum means left axis deviation. That's it's a usually clinical teaching, no? So why is
Yes,
it
sir.
happening? Okay, okay. Ask sir. Suresh sir might explain.
Yes, sir.
So in A completed. Shankar, you
Hello?
completed or anything else? This is the last slide.
Yes, sir. This is the last one, sir. This is the last one.
Okay. So to complete this, as he told, you have to go for medical blood investigations, ECG, X-ray. X-ray nowadays we are X-ray is okay. Nowadays we are doing echo if possible. TE. The thing is ASD should be closed because medical treatment I have to tell for the students. That's why
Yes,
initially
sir.
medical management. Then if the patient is symptomatically worsened, we have to go for an intervention. Normally, any ASD should be intervened if the pulmonary to systemic blood flow, that is QP by QS, 2.2. That the pulmonary blood flow to the systemic blood flow is more than 2.1. There's a class 1 indication that it should be closed either by your device. What is the device? It is device suitable, you have to put a device, or if it is surgically possible, you have to do. So the first indication for any closure of ASD is QP by QS, symptomatic ASD with the QP by, that QP means pulmonary blood flow divided by QS means systemic blood flow, more than, the ratio should be more than 2.2. If it is 1.5 to 2.1, there are other features. If you are going for other surgeries, if you are going to open the heart, then it can be closed. But less than 1.5, still it can be medically managed. So that is the first thing. So you have to assess by echo wise, you usually assess QP by QS. So with that only, we are going for a closure. During closure, we will assess all the rims of the ASD. There are 6 rims. We will assess all the rims of the ASD. If the rims are okay, then it can be, you can go for a device closure. If it is not possible, if the ASD is more than, there are some certain conditions where the device is not properly fitting, like deficient rims. And if the ASD is more than 34 or 35 millimeter in size, 30 millimeter, large ASDs, because the retention disc of both left atrium and right atrium will not sit properly if the atrial septal defect is large. So when there is a large atrial septal defect, it is difficult to close. And where the atrial septum is ostium primum type of ASD, we won't usually close because it is near to the AV node and there is high chances of possibility the patient may go for an complete heart block. So we won't close. That kind of cases, you have to submit the patient for surgery. A proper ostium secondum with less 25 to 30 millimeter maximum with adequate rims can be closed by your device. Otherwise, the patient should be submitted for surgical closure. Other sinus venosus type and your ostium primum, common atrium, these kind of ASD should be better always closed by a surgical closure before the development of your pulmonary hypertension. And there is one another entity, you have to assess the reversibility by doing cath or your echo itself, you can find it out. And if at all, if possible, you have to go and do one cath to find out the reversibility. If there is a irreversible condition, you are not supposed to close. If you close and pulmonary Eisenmenger ASD, what will happen, Shankar? If there is a severe pulmonary hypertension, irreversible pulmonary hypertension, you close the defect, what will happen? Shankar?
Sudden decompensation may develop in the patient.
What decompensation? Which chamber?
Left, we have to do a balloon occlusion test prior.
Which heart failure will be happening? Sorry, sir.
Left.
No.
Okay, sir.
You are closing the defect, Shankar. Now there is no. Actually.
Right ventricle.
Yeah. Severe right heart failure will happen and the patient die of right heart failure.
Acute RV failure.
Okay, acute RV failure, the patient will die of that one, not your LV failure, because now the RV is decongested through ASD into the left side. Since the development of pulmonary hypertension, RV is having 2 outlets. One is pulmonary artery, another one is through RA into the ASD into the left side. So actually, ASD is a protective effect for these individuals. If you inadvertently close that, the patient will go for RV failure and death.
Yes, sir. Okay, sir.
So if the patient develops cyanosis in a pulmonary hypertension, you can close by a what is called this punctured or fenestrated ASD. They used to say fenestrated means some amount of blood will go from the right atrium into the left atrium through the ASD itself. That is called fenestrated ASD, where that can be the one used to prevent RV failure and to reduce your cyanosis. Okay.
Okay, sir. Okay.
Sir, anything else, sir?
Nothing, sir. Just regarding Shankar, that ECG for ostium septum usually happening RV that left LA to RA shunt. So RA RV is volume overloaded, right? So its RV is LA. So the mean QRS vector should be shifted to right. So this is the reason for right axis deviation in case of ostium secundum. So it's everyone we can easily understandable. But regarding ostium primum, so you already partially mentioned, it's usually associated with endocardial cushion defect. So endocardial cushion defect means it's a lower part of atrial septum and AV valves, and the conduction system alignment includes. So what happened here in ostium primum means AV node is usually displaced inferiorly or posteriorly. So the left anterior fascicle will be hypoplastic or usually will not be participating. So,
Okay, sir.
so usually this is the reason for left axis deviation, I think.
Okay, sir. Okay, sir. Okay, sir.
Yes, yes.
Okay, Shankar. Good. So, will you advise infective endocarditis prophylaxis for this lady or not?
If the patient is undergoing any procedures, we
Yes,
can
that is
give,
the
sir.
question. Infant
Yeah.
endocarditis always before procedure only. Will you
Yes,
advise or
please.
not?
Yes, sir. We can. Yes, sir.
Yes, sir.
Will you
Because
advise?
whenever there is a turbulent blood flow or
Oh, no.
it is
Did you read the guidelines? Did you read the guidelines for IE?
Please take home message should be from
yes,
we should not be case for please
See,
sir
please.
yes,
Yeah. Please,
yes,
these
sir.
are the 5 conditions you have to put IE prophylaxis. Okay.
Okay,
This
sir.
is in any patient under prosthetic valve, any patient having a previous history of IE.
This is the first
Okay, sir.
one.
First point, any patient is having a prosthetic valve implantation.
Okay, sir.
Okay, third one is complex congenital cyanotic heart disease, which are partially repaired or palliative shunt or repaired with the first 6 months. These are the
Okay,
5
sir.
categories you have to put IE prophylaxis. No other go for no other condition needs IE prophylaxis except these 5. Prosthetic valve
Okay, sir.
implantation, previous history of IE, complex congenital heart disease, which is partially operated, which is palliated or fully operated in the first 6 months of successful full repair. These are the 5 conditions you have to give IE prophylaxis. No other condition you need not give IE prophylaxis.
Okay, sir. In this case, it is an uncorrected acyanotic congenital heart disease till 50 years, sir. Even for this, we not give, sir.
Definitely don't give.
Okay, sir.
It is
Okay,
a
sir.
simple acyanotic congenital heart disease. More importantly, the left to right shunt between right atrium and left atrium will be very less. The pressure difference is very less.
Okay, sir. Yes, sir.
Shunt is not that much big. In the case of
Yes, sir.
VST, the
Yes, sir.
left to right shunt will be more because of the left ventricular pressure is more than that of right. In the
Right,
left to
okay,
right,
yes, sir.
the pressure difference hardly 6 to 8 millimeter.
Okay, sir.
So the shunt is not that much powerful to produce endothelial injury.
Okay, sir. Okay, sir.
So the take
Okay,
home
sir.
point in this case, Shankar, if the patient
Yes, sir.
is unrepaired, no need to give an infected endocarditis prophylaxis. If the
Okay,
patient
sir.
is subjected for repair, surgical repair or prosthetic repair, first 6
Okay, sir.
months the patient need IE prophylaxis, not after that. So after
Okay, sir.
surgery, first 6 months is the period for acyanotic heart disease, right?
Yes,
Yes,
sir.
sir.
Okay, Shankar. Okay,
Mm.
good.
Yeah,
Otherwise,
really, thank you. Yeah. Anything else to be discussed, sir? Raja,
yes,
Sudhanshu?
sir. Yes, sir. Yes, sir. Cardiologist has covered most of the
Yeah.
topics. Yes.
Any final input regarding his presentation quality, sir, that needs to be informed to the student so that he gets the input so that he can improve the presentation quality next time also. That's it.
Yes, sir. He
Exam oriented points. You can just give him 1 or 2 points so that he can improve on the next time presentation.
yes, sir. Yes, sir. He has covered nice presentation, sir. Actually, it's more than enough extraordinary presentation, sir. But the thing is, as cardiologist said, that regarding JVP, whenever if JVP is elevated, we need to mention about the waveforms. That should be included. Then
Okay.
regarding
Yeah.
that should be included. Yes. Then anthropometry, he has clearly mentioned. Then in any cardiac patient, you need to look for thyroid. So if at all,
Okay,
if
sir.
it is a thyromegaly, so any hyperthermic circulation, cardiac failure, it should be one of the differential diagnosis, any female or whatever. So
Yes,
you
sir.
need to look for that also.
Yes,
Then
sir.
yes, as heart sounds means you need to explain all the heart sounds. First,
Yes, sir.
second,
Yes.
third, fourth. Then you need to discuss about the murmurs. Murmur, if at
Yes,
all
sir.
is murmur is there means you need to discuss all the 8 to 10 points, including dynamic
Yes, sir.
auscultation. So as a PG,
Okay.
so some grade, what is the inspiration or expiration, what is the diaphragm of the scope, what is the quality of the murmur, everything should be described in detail. So
Okay, sir.
otherwise, yeah, you made a very clear presentation. Over to Suresh sir. So Suresh sir, you
Yes, sir. Yes,
give
sir.
me some input.
As rightly pointed out, everything is there. Once you complete your case sheet writing, you go once back and recorrect everything because
Okay,
sometimes,
sir.
so some are points you told hyperdynamic and only lateral shift, something like that. So it's
Okay.
like a mathematics. You go once
Yes, sir.
again and
Yes, sir.
rethink about your finding Because while we auscultate, we will have this finding, that finding, that's a difference of opinion. But once we write everything, come to a conclusion, then you may modify some of your findings. Okay.
Yes, sir.
So that you
Yes.
always do. Once you write all the case sheet, not in this cardiology, everywhere, every system, you once write everything, then go back once again and fitting your diagnosis to your findings. Your findings should fit your diagnosis. Nobody
Yes,
bothers about your diagnosis, but everyone bothers about your finding. You clear in
yes,
your findings. So if
okay,
possible,
sir.
put all your findings into the diagnosis, because don't contradict your statement, your finding with your diagnosis, because you are going to tell everything, and if there is a dysynchrony, it is difficult for you to explain. Like that, you
Yes,
only lateral shift, then they may ask with hyperdynamic, with only lateral shift, what are the conditions? They will ask like that. It is difficult
okay,
to
sir.
answer. So always you
Okay,
correct
sir.
everything, you write everything, go back once again, read full case sheet if there is any possibility to change, because once you read everything, you will understand where you have to modify. Just to modify before presenting. Okay, even in
Okay, sir.
exams, that's a good thing. And
Okay,
other
sir.
thing already pointed out by Raja sir, Rajamendra sir, everything is okay. So hard sounds, especially auscultation, you don't skip any hard sounds. It's like
Okay,
a
sir.
mnemonic, where 1, 2, 3, 4, like 1, 2, 3, 4, everything is mnemonic. So these and all basics.
Okay,
If you
okay, sir.
if you are not presenting basic properly, they may intervene in that, and they start
Okay,
asking
sir.
question in this. So try to
Okay, sir.
present basic things fully. Like sir
Okay, sir.
told, murmur, you complete everything, 8 points, 9 points, complete fully. So if you
Okay, sir.
start boldly and loudly present, nobody will intervene. Okay, these candidates notes everything. That's let us stop and listen him. Like that, the attitude. So don't give chances. You just complete it.
Yes, sir.
Yeah. I think Shankar Narayan might have got some tips from the faculties of experts how to present. Just my suggestion is just to try to make your short case examination. Out of your 15 minutes, just take only 10 minutes. Try to develop the skill of examining in 10 minutes time. Remaining 5 minutes, just recap, understand the combinations of symptoms, signs, and your diagnosis. If it's not matching, give some breathing time to re-examine also,
Yeah,
or
yeah.
Okay, sir.
rearrange your findings. That's very important. If you're going to have the habit of examination 15 minutes completing without any breathing time for to think about what is your finding, it's very difficult to give an explanation at the time of discussion. So always
Yes,
develop
sir.
the skill of examining on your own 10 minutes time. Take 5 minutes
Okay,
for
sir.
your breathing time. It's only
Okay.
a skill, that's all, nothing else. So unless you do
Yes.
it repeatedly, you'll get the skill of examining 10 minutes time. Okay?
Okay, sir.
Small
Yes.
suggestion. Otherwise, you did a good job in presentation. Both
Okay.
discussion
Thank you.
aspect also, you did a good job. Appreciate you.
Yes. Thank you, sir.
Yeah. Anything else to add, sir? Or can we call it a day, sir?
Yes, sir. Yes, sir. Thank you, sir.
Yes.
Yeah, really. Yeah, thank you, Dr. Raja
Yes,
Magendran, sir, and
yes.
Suresh Kumar, sir, for this wonderful discussion.
Thank you,
Appreciate
sir.
Dr. Shankar
Thank you, Suresh.
Narayan for this. Yeah,
Thank you,
Suresh.
Raja
Thank
sir.
you. Thank you, sir. Thank you. Good night. Good night.
Good night,
Thank
sir.
you, sir. Thank you, sir.
Bye, sir. Bye, Shankar. Bye.
Thank you, sir.
Thank you, sir.